lung, increased increased forms of VTE2. So nevertheless, without spending any more time, I would like to introduce our esteemed faculty for the day, our esteemed speakers for the day, who would throw more light on multiple topics related to thrombosis with a focus on COVID-19. To start with, we have as our prolific speaker, Dr. Tiny Nair, who is a senior consultant and head of the department of PRS Hospital, Trivandrum, Kerala. Sir has been awarded multiple awards throughout his career, including the Best Doctor Award by the Government of Kerala in 2006, Most Inspiring Doctor of India, Economic Times 2019, and the Best Reviewer by the very reputed Annals of Internal Medicine in 2019 and 2020. He is also in the editorial board of multiple reputed journals, including Hypertension, Indian Heart Journal, Kerala Heart Journal, and the European Journal of Heart Failure, the Indian edition. He is also a member of the Hypertension Council of the CSI, and has authored more than 5 books, the latest being Magic of Indian Medicine. Overall, he has 64 publications and 3 national orations to his credit, and is also a TEDx talk speaker and a top writer at the Quora blog. We also have with us Dr. D. Prabhakar, who is an interventional cardiologist at Ashwin Clinic, Apollo Group of Hospitals, and Dr. Mehta Hospitals in Chennai. He is a co-author of the Lipid Association of India Expert Consensus Document Part 1, 2, and 3, the Consensus Statement on Management of Heart Failure and Diabetes, and the Position Statement on Antithrombotic Therapy in COVID-19 by the National Health Mission of Tamil Nadu. His current research focuses more on cuffless PP with CSIR series, pulse measurement with a camera, ambulatory blood pressure monitoring, apolipoprotein B versus LDL cholesterol, and resistant hypertension. He's been a primary investigator and lead of the Heart Failure Registry of Tamil Nadu for the CERT group, and is an author of 39 out of 40 chapters in cardiology in the Apollo textbook of medicine. Finally, we also have as our esteemed speaker, Dr. Kiran Prajapati, who is a senior consultant and director at White Lily Cardiology Clinic, Subhas Bridge, Ahmedabad, and also practices at multiple institutes across Ahmedabad. His area of interests are with complex coronary interventions, clinical cardiology, with a focus on hypertension, lipidology, heart failure, and coronary artery disease, and is known for his intervention on complex radial interventions. He has also published various articles and case report in journals of national and international repute, and has been invited as a faculty too for multiple national as well as international workshops. He has been certified as AFESC and International Associate of SCAI, and had successfully completed his ICCPR. Gentlemen and ladies, the talk for today would focus on 3 topics with 20 minutes given to each speaker. The first topic being an overview of antithrombotics by Dr. Prabhakar. The second topic being prevention of COVID-19 coagulopathy by Dr. Nair. And finally, NOACs, need to understand in a better way, by Dr. Prajapati, which would be followed by a short Q&A. Without spending any more time, I hand over the session to our first speaker, Dr. Prabhakar. Sir, over to you.
Thanks, Dr. Patsadi Muglidharan. I think it's an honor to be with Dr. Tiny Nair always. He is a star, whom I like. Patsadi said, I've always admired Dr. Tiny Nair and the speed and the gather that he has with the subject, and it's an honor to be with you, Dr. Tiny sir. Now, I will not waste much time. Thanks to Dr. Patsadi for giving us an opportunity to share with us. What I will try to do is over the next 20 minutes as he has given me, and I will try to gather and give you as much information as possible on an overview of antithrombotics. Now, when I tried to look at this particular topic, what happened was, looks like I made a huge mistake. It's like trying to look at all the tourist spots in India in 20 minutes. Then I realized that it is not possible. So I thought I will touch on the major aspects, give you a few glimpses of these antithrombotic therapies, and come to that. So whenever you start, you always start with the history of what happened. So the history of antithrombotics and the thrombosis starts with a great gentleman by name Virchow. The Virtuous Triad is the basis of thrombosis. Basically, what is it, Virtuous Triad? There are three things that contribute to the thrombosis. One is the endothelial injury and the exposition of the subendothelial layers, hypercoagulability, and abnormal blood flow. So these are the three major factors that are going to be involved. Now herein, we are looking at thrombosis. Now clinically, whenever you think about thrombosis, you look at two kinds of thrombosis: the arterial thrombosis that happens in the coronary arteries or the cerebral blood vessels, or you have a venous thrombosis. I think we'll talk about the coronary arteries and the venous thrombosis, prototype being the venous thromboembolism. Now, what is the difference? Look at the left panel, you will realize that you are seeing a arterial thrombosis where there is a plaque that develops. The shoulder of the plaque is not steady, and because of the excessive flow, because of the shear stress, there's a conformational change which happens, because of which there is a shoulder exposed and the subintimal or subendothelial layers are exposed, and because of which there is an increase in what is called as the platelets. There is a white thrombus which contains predominantly platelets, fibrin, red cells, and degenerating leukocytes. But what happens in venous thrombosis, like a deep vein thrombosis, it's slightly different. The pathogenesis is different because the treatment is going to be different. What happens is the periphery. What happens, there is a low shear flow. There is nothing like the high shear flow of the arterial system. So here in what happens is you have a predominantly red thrombus which contains enmeshed blood cells with a few platelets. Basically, there are plenty of fibrin strands in the line of Zahn. So this is the difference. And so here you notice that there are two components predominantly involved: the platelets and the thrombus. And when you look at these two components, we first look at the platelets. When you look at the platelets, what happens is platelet activation happens. Once there is an endothelial injury, there is an exposure, adhesion, activation, and aggregation of platelets. In simple terms, how the platelets work. But what are the factors? There are several factors: the collagen, the ADP, the thromboxane A2, the 1 milligram factor, or thromboplastin. All these things are exposed. Platelets gets activated. As platelets get activated, platelets beget more platelets. There is an amplification. And ultimately, these platelets combine with fibrinogen and form a stable clot. This is how it acts. If you look at the history of how this whole story of the thrombosis happened, since I said I'm giving you an overview, the story started very early in 1916 with the discovery of heparin. But the first clinical use came as late as 1937. Then the Kumarol was isolated in 1939 and it came in 1954. Then subsequently, since the 1970s, there has been an acceleration of events. And then what we found out, different drugs were found. The first thing was 1980, the aspirin was approved for prevention of myocardial infarction and stroke. Then the ticlopidine came, then the clopidogrel came, the prasugrel and the ticagrelor all started coming. In the meantime, there was also a surplus of the anticoagulants also coming in. Once the heparin came, then the low molecular weight heparin came, fondaparinux came, and then you had the NOACs or the DOACs or the novel anticoagulations or direct acting anticoagulations came. One word about the antiplatelets: when you look at the overall spectrum of the antiplatelet agents, you notice that there are the thromboxane synthesis inhibitors, prototype being aspirin. The aspirin is simple, it prevents the inhibition of thrombotic. Then you have cyclic AMP enhancer like dipyridamole. We're not going to talk about that. The P2Y12 receptor inhibitor, ticlopidine, clopidogrel, prasugrel, and the cangrelor, ticagrelor. All these come into this. Then you have a 2B3A antagonist, which is going to be abciximab, eptifibatide, and darolutamide. I'll not talk much about 2B3A antagonist because we are talking predominantly from a physician point of view today. So just to give you what happens when there is a plaque that gets disrupted, like I told you there is going to be a plaque that is disrupted when the shoulder of the plaque gets disrupted. You'll notice that the tissue factor, the collagen, and the 1 milligram factor, all that are subendothelial get exposed. There is platelet aggregate adhesion and secretion. ADP gets activated. What happens is the clopidogrel, prasugrel, and the ticagrelor block the ADP and prevent further recruitment of platelet and activation. Why does the aspirin act in a different pathway where there is a COX-1 inhibition where the thromboxane A2 is blocked? Now, if you look at the other side, look at the tissue factor, you notice the tissue factor goes into factor 10A, thrombin, and here at the factor 10A inhibition, you have rivaroxaban, apixaban, edoxaban, about which we talk later. And the thrombin itself, you must realize, is going to produce platelet recruitment and activation. So these are not separate mechanisms. The thrombin is separate and the platelet activation is separate. Both of them work together, and you must understand that both of them have to be tackled together. From now onwards, what I thought is I will give you only interesting information on the antithrombotics. Because if you go into individual drugs, you're going to get bugged, and maybe most of you will start sleeping. So what I thought is I'll give you some interesting information which is often missed, more like the myths and facts of of these antithrombotics. Now, what we commonly do is use aspirin. Aspirin is the most commonly used antiplatelet drug. So when you start using aspirin, you use a dose of anything from 75 to 325 milligrams, and one of the very common dosages that we use is 150 milligrams. Now, what is the difference between 75 and more than 75? If you look at the results of this, the meta-analysis of the antithrombotic trialist collaboration clearly showed that the efficacy is the same at whatever dose. Only thing is, if you increase the dose of aspirin, you only increase the amount of bleeds. So the first message I want to give you today is start using aspirin, not more than 75, which has also been clearly outlined in the Plateau trial with ticagrelor, which I'm not going too much that, but I'll just mention it to you and tell you that aspirin, don't use a higher dose, use a smaller dose. The bleeds are less, but the efficacy is pretty much the same. The second point is what came yesterday. Now, this is the task force recommendation from the US Preventive Services Task Force, which came on 12th October 2021, which is yesterday, which said clearly that patients older than 60, they recommend against initiating low dose aspirin for primary prevention. Now, if you're between 40 and 59, there must be a careful interaction between the physician and the patient to understand that there is an increased risk of bleed, and also simultaneously understand that the benefits are limited. So ultimately what it boils down to is in primary prevention, be very clear about this point. It is not secondary prevention. We are talking about primary prevention. In primary prevention, there is not much role for aspirin at this point of time. Now, what happens when there's a blood vessel injury? You will see that there are three things happen. Blood vessel vasoconstriction, the platelet starts aggregating, and there is also the coagulation cascade that starts activating. Now, we said during the primary prevention, there is not much role for aspirin. Now, if you look at the original trials, why did we start using aspirin? Because they started using aspirin because in the original trials, like the physician study, they found aspirin was useful. But what happened there? There was no use of statins at the time. This was at a time in the pre-statin era. Now, what do the statins do? Basically, when you look at a plaque like this, there is a stabilization of plaque, which happens only with a high-intensity statin. The plaque stabilizes, and there is no shoulder like this here to expose to the shearing stress to produce an unstable plaque. So if you give a high-intensity statin, there is not only going to be regression of plaque, but there is also going to be stabilization of the plaque. And so probably you don't need an antiplatelet agent. It doesn't stop with that. The statins have been proven to have antiplatelet effects and the antithrombotic effects also. I'll just give you the reference to this because it's a much bigger topic, which I don't want to push in at this point of time. Now, the other antiplatelet agents which we saw over time was clopidogrel, which came first. Then the prasugrel was introduced, and finally the ticagrelor. What is going to be the difference if you start looking at it? The onset of action of clopidogrel at 300 milligrams is 8 hours, and at 600 milligrams is 2 hours. But look at the onset of the loading of prasugrel, 30 minutes. But ticagrelor takes about 2 hours. But technically, they say that it takes in about 40 to 45 minutes also. This is a very important point you must understand, because on the cath lab table, if you want to load these patients, you must use these drugs. The second point in this slide I want you to notice, the platelet function recovery time is 5 days with clopidogrel, 7 days with prasugrel, and 2 to 3 days with ticagrelor. Now, the results of the ticagrelor trial, this originally the gold standard was clopidogrel. When the Plateau trial came in, it clearly showed that ticagrelor was superior by about 16%. And if you look at the bleeds, there was no significant bleeds. So ticagrelor seems to be the drug of choice in these patients. But when prasugrel trial, the Triton-TIMI 38 trial was compared, again, there was a much superior benefit, 19% statistically significant benefit of prasugrel over ticagrelor, comparing with the dual antiplatelet therapy with clopidogrel. Now, if you look at the bleed, herein was the problem, because there was a significant increase in the bleed with prasugrel, which was significantly important. Now, if you compare these two agents, is there any major trial? There was the ISAR-REACT 5 trial, which showed, actually this trial was conducted to show superiority of ticagrelor over prasugrel. But actually when the trial was done, it went south and showed that prasugrel was superior and the bleed was much less. It's a very one-off trial, but we must accept that ticagrelor and prasugrel, there are some issues with that. But there are a lot of limitations of this trial. We will not go into that, but understand both are good drugs, but on the cap table, there is a very good benefit for using ticagrelor. Now, aspirin has always been the mainstay. Now, can we have an angioplasty or a procedure without aspirin? There's a very interesting trial called the ASET trial, which came in and studied patients who were given just prasugrel without aspirin. And this is a very short-term study which showed clearly that prasugrel alone, without even aspirin, following a stable PCI, it's not an ACS PCI. In a stable coronary artery disease, you're going to do a PCI. You can still use only prasugrel, and the long-term or the short-term outcomes are pretty good with these group of patients. So ultimately, it boils down to giving dual antiplatelet therapy. How long do you give? Whom do you give? Now look at this. If you have a stable ischemic heart disease, there is no role for dual antiplatelet therapy. Be very clear about this. There is no role for dual antiplatelet therapy in stable ischemic heart disease. But if you have a patient post-PCI in a stable ischemic heart disease, treadmill positive, no chest pain, you do an angioplasty and you do a drug-eluting stent, you continue for 6 months. I'm not going to the bare metal stent because you hardly use it nowadays. You continue for a minimum of 6 months, and beyond that may be reasonable depending on what condition is happening. What about post-CABG? Maybe you can continue for a period of 12 months. But what about ACS patients, NSTEMI and STEMI patients? Now, this is the interesting part. You look at most of the indications, medical therapy, lytic therapy, PCI, or a post-CABG, you will notice that most of these patients are going to require it for a period of 12 months. Beyond 12 months is a big question mark. Now, what do we do in clinical practice? Most of us just continue the antiplatelet therapy and don't stop them. And in between, these patients come to us and say they want to undergo a non-cardiac surgery. Now, what do you do for these patients? We'll ditch the BMS group and we'll look at only the DES group because that is what's happening. Within the first 3 months, as far as possible, try to defer. Now, recently there is a paper which says you can overlap with Cangrelor and then do it, but it's not available here. So I don't think we'll talk about that. But if you're going to be between 3 to 6 months, it's an amber area. What you can do is you can proceed with surgery if required, but generally you continue aspirin and discontinue the second antiplatelet and restart it as early as possible. But beyond 6 months, you can stop the drug and use it. Now, this is the current status of these drugs. Now, how long do you stop? We already saw what the answer to this question was. 3 days for ticagrelor. It is going to be 5 days for clopidogrel and 7 days for prasugrel. Aspirin, in fact, nowadays what we say, you can probably continue it through the surgery. This is the recommendation from the European Society of Cardiology, 2017. Now, what is the problem with giving these antiplatelet agents? Some of these patients require long-term therapy depending on increased ischemic risk, basically the elderly, the ACS presentation, multiple MIs, extensive disease, diabetes, CKD. Regarding the stent, ACS presentation, the older stents, the stent underdeployment, undersize, all these things have actually come down much more because of the imaging modalities that we keep using, bifurcation stenting, left main stenting, these are troublesome. But you must also be wary of the increased bleeding risk in a patient with prior bleed, oral anticoagulation, female sex, advanced age, low body mass, chronic kidney disease, diabetes, anemia. That's a very important factor. Any patient who's on a dual antiplatelet or long-term antiplatelet, the anemia is there. Probably there has been a bleed somewhere, so be careful with anemia. Anemia is a very important clinical sign. Chronic steroid therapy, you must also be careful. Now, what happens if you look at the intracerebral bleeds? You will notice that the DAPT long-term, there is a 42% increase. The only reason I put this slide, this came in JACC about 2 weeks ago, but the reason I want to put this slide for you is just to show you there is a very high incidence of problems. But today, because of the high incidence of bleed, we want to do more of de-escalation strategies. What are the strategies? Probably withdraw aspirin, convert from a potent drug like a prasugrel or a ticagrelor, which is superior to clopidogrel, reduce the dose from probably 10 milligram of prasugrel to a 5 milligram prasugrel, or 90 milligram to 60 milligrams of ticagrelor twice a day, or continue aspirin alone. There's a lot of data. It's a very interesting study published about 2 weeks ago. Again, this is in Journal of American College of Cardiology. I'll not go into too much of detail, but I'll tell you, if you look at the comparison versus de-escalation, look at it. Clopidogrel, low-dose prasugrel, or ticagrelor, everywhere it favors de-escalation. But what about the bleeding outcome? Bleeding outcome also seems to be favoring de-escalation. So the current concept is not to give dual antiplatelet therapy for a long time. The only thing that happens if you give long-term dual antiplatelet therapy without a clear indication is going to be increased bleeds. So you have to select your patients, and some patients with a very difficult angiogram could probably use. So what are the dual antiplatelet therapy modalities? Clopidogrel, prasugrel, ticagrelor, and the new one that's happened is a rivaroxaban 2.5 milligram twice a day. Now, the European Society of Cardiology came up and said, who are the candidates for that? Now, think about this carefully. Persons who are at high risk for ischemic events, primarily meaning that those with diffuse multivessel coronary artery disease with either diabetes, recurrent MI, peripheral arterial disease or CKD, or moderate risk with any of these factors, including heart failure. Now, those patients are going to benefit. The dual pathway inhibition blocks the antiplatelet and the rivaroxaban blocks the thrombotic agent also. Now, there is a lot of benefits with this. I will not go into this, but what I want to tell you is, as the number of risk factors like diabetes, renal impairment, heart failure, or a peripheral artery disease increases, the benefits of these drugs seems to be much, much more. So you must understand that this is not a very smooth sailing like this. You must understand that there is going to be a problem. So what is the benefit? If you use rivaroxaban, the number needed to treat is 77, while the number needed to harm is 84. Now we are looking at chronic long-term dual antiplatelet therapy. What about ticagrelor? Number needed to treat is less than the number needed to harm. So it seems to be more harmful based on the Pegasus trial. But the safest two drugs for long-term dual antiplatelet therapy seems to be clopidogrel. Probably based on the DAP trial, the prasugrel, I would vote for clopidogrel. Number needed to treat of 63 and number needed to harm of 105. Now, next we go into the anticoagulation, about which we briefly spoke about. There are several drugs. The anticoagulation that we know prototype is the unfractionated heparin and the low molecular heparin, which is antithrombin 3 potentiators, which blocks the different factors. Fondaparinux acts also as the similar action, but it blocks only the anti-10. Then you have the vitamin K antagonists, which block the vitamin K related anticoagulant factors, the 9, the 10, and the 7. And you have these factors that work predominantly. What is happening now today is we are talking about the newer drugs. Mainly what we're talking about is the two drugs, the two groups of drugs, the factor 10A inhibitor, which is going to be rivaroxaban, apixaban, and roxaban. Then you have the factor 10 inhibitor, which is the dabigatran, which acts one step below in the coagulation pathway. Now, the different anticoagulations, as I have said, you have the parenteral, the oral. The parenteral are going to be the indirect thrombin inhibitors, unfractionated heparin, low molecular heparin, fondaparinux that we know. The direct thrombin inhibitors, the bivalirudin and hirudin are the prototypes. And if you look at oral drugs, we know the coumarin derivatives, which is warfarin prototype. Factor 10A, like we said, is going to be rivaroxaban, apixaban, and the direct thrombin inhibitor is going to be the dabigatran. So differentiate between the three drugs. One thing you must understand, dabigatran acts a little differently on the thrombin. Rivaroxaban and apixaban are anti-10A inhibitors. One of the differences is that you can't break the dabigatran and put it in the Ryle's tube. Remember, the rivaroxaban can be crushed and given in the Ryle's tube if you want to give it to these patients at home. The first thing about the DOACs is that these are predominantly being studied in venous thromboembolism. This is the pulmonary embolism that is there. Now, I'll just tell you one thing. Most of the patients with unprovoked deep vein thrombosis require 3 months of anticoagulation. You consider indefinite or long-term therapy for unprovoked DVT or a recurrent DVT. That is important for you to understand. There are several trials of all the three molecules, and all the three molecules have been found to be pretty efficacious in usage in these drugs. And you must also understand that depending on the kidney functioning, the dosage can be altered. Most of the drugs can be used with the creatinine levels of up to the creatinine levels of about 30 ml per minute. Below that probably is a little shaky. Probably the best drug that has been studied is apixaban, where you have two of the three criteria, basically an age more than 80 or weight less than 60 or a creatinine that is more than 1.5. You have two of the three criteria, use 2.5 milligram twice a day. Otherwise, you use 5 milligram twice a day. The last point I want to talk about is the atrial fibrillation. Atrial fibrillation, the primary point of interest is prevention of thrombus. The morbidity of thrombus is high. Most often people start using aspirin. Now, I want to mention this point about aspirin. The bleeding risk on aspirin is not different from vitamin K antagonist and NOAC. So it bleeds as much as a NOAC. But if you look at the efficacy, it does not have efficacy. So you have a bleed with aspirin, but no efficacy in prevention of stroke. That is very important. So how do you assess this? Because the CHADS2-VASc score and the HAS-blood score, which I think all of you are aware of, you can load it down. If you're having a CHADS2-VASc score of more than 1 in a male or more than 2 in a female, because the S in that is the sex, which is every female will have 1. So you need to have 2. Or if you have more than 2, definitely you need an anticoagulation. If it's 1, you consider anticoagulation looking at the patient. Now, first among the equals, which is going to be the best drug. Now, clearly, look at this panel down. This is going to be the safety, and this is going to be the safety. The safest drug is possibly, we are not looking at rivaroxaban because it's not available here, apixaban. But if you look at efficacy, come this side, which is the most efficacious drug, that is going to be the dabigatran 150 milligram twice a day. So the most efficacious drug is going to be number 1 drug is going to be dabigatran. But if you look at the safety aspect, then you look at edoxaban 30 milligram and then look at apixaban. Dabigatran one time, dabigatran goes down. Rivaroxaban holds down based on the original trial. So If you want a patient with recurrent thromboembolism, like for a recurrent atrial fibrillation stroke, or a young person who's got a low bleeding risk, probably dabigatran would be the drug of choice. Now, what are the things that we commonly do? Whenever you think of bleed, what we commonly do is we start giving a low dose. We are scared of bleeding. So what we try to do is we don't give a full dose of anticoagulation. So instead of giving the 150 twice a day of dabigatran, we start using a lesser dose. Or instead of giving the 5 milligram twice a day of apixaban, we start using a lesser dose of 2.5 twice a day. Now look at what happens here. You look at this particular panel, the stroke risk is going to be 3.3 to 6.7. And if you look at the bleeding risk, it is going to be higher. Now, what happens here is you will notice that with the Aristotle and the Rocket AF, the bleeding risk actually is higher with the low dose. You lose the efficacy, and the bleed is not reduced. The bleed is actually higher. That's important. Now, practically for any cardiologist, the biggest problem is when you have a patient with atrial fibrillation or a patient who's got a stent inside, what do you do with the anticoagulation therapy? That's a very important practical question which all physicians should know, because even yesterday I saw a patient on a dual antiplatelet therapy 2 years after a stent taking an anticoagulation. Now, is that correct? What happens to that? When you combine dual antiplatelet therapy for a long term, there is a 1.8 times higher risk of bleed. So if you combine it with the vitamin K antagonist like warfarin, the bleed seems to be 2.5-fold higher. Now you must understand clearly higher incidence of bleed. So what is the current recommendation? If you have a large vessels, stable patient where you don't expect a problem, you give an anticoagulation therapy for a very short time. By discharge, you can shift the patient to a single antiplatelet like clopidogrel and then continue the anticoagulation. For a difficult PCI, you can continue for 1 month or 3 months, depending on what happens. But after that, you continue clopidogrel with an anticoagulation and then continue. But look at what happens at the end of 1 year. This is very, very important. All of you should understand. At the end of 1 year, you just continue the NOAC. You don't need antiplatelet agents. That is sufficient. Be very clear. You don't need an antiplatelet even after a stenting. This is post-PCI patients we are talking about. So you need only an anticoagulation. You don't need the drugs. So when you practically start using anticoagulation, which is the drug that you choose? There are certain indications where it's useful. One thing very clear is recurrent stroke, TIA, despite well-controlled vitamin K antagonist, wherein you have a problem, probably the best, most efficacious drug is dabigatran 150. If a patient has moderate to severe renal impairment, the apixaban and the rivaroxaban seems to be having the best benefits. When there is a high risk of bleeding, probably the best drug where the risk of bleed is lowest is apixaban. Or if you want to use a dabigatran of 110 milligrams. GI symptoms, don't use dabigatran because it contains arsenic and it contains tartarate, which can worsen the kidney. So you have to use apixaban or rivaroxaban. High risk of bleeding, again, a low dose of dabigatran or apixaban. Patient's preference, if he says that I don't want to take 2 drugs a day, you don't have a choice. You probably have to give rivaroxaban for these patients. Now, this is one slide I thought all of you should be aware of, because the GI bleed is a big problem. Now, this is a very simple study in JAMA, which came in 2018, which showed that just by administering a PPI, you reduce the incidence of bleeds. Compared to no PPI and a PPI co-therapy, the incidence of bleed is reduced. So I think all of us should put all the patients on anticoagulation on a PPI to reduce the bleed. Now, a couple of off-label indications, which I think Dr. Kiran Prajapati might take, but I thought I'll give you 2 important, interesting points about the anticoagulation. When you have an LA appendage thrombus, there is still a limited data on NOAC usage, and LV thrombus also. There is a very interesting data that says that this can be useful. Now, finally, I will close with my take-home messages. I think I've taken too much of time. First thing is antithrombotics are not just anticoagulation. It includes the antiplatelets and the anticoagulation. Aspirin has a very limited role in primary prevention. DAPT, carefully weigh the risk of ischemia and also weigh the risk of bleeding. Make sure that you have a trend towards de-escalation. Probably in future, we may not have aspirin alone. We probably may have just the newer anticoagulation, just newer antiplatelet drugs, just one of these drugs. Dual pathway inhibition is a new concept. It seems to be very effective in very high risk patients, but caution, because the number needed to harm is not very high. NOAC or DOAC, most of the indications on chronic anticoagulation, it works. Aspirin, there is no role for in atrial fibrillation. In the venous thromboembolism, basically meaning pulmonary embolism or of a deep vein thrombosis, standard therapy is 3 months. Low dose DOAC is more harmful because it can actually produce more bleeds, but less of efficacy. PPI for most cases to prevent a GI bleed. Combination of single or dual antiplatelet therapy with anticoagulation maximum of 1 year, not more than that. Clearly understand, beyond 1 year, you really don't have to give antiplatelets, just the anticoagulation is sufficient. I'll close with what Bill Gates said. He said, humanity's greatest advances are not in its discoveries, but in how those discoveries are applied. Finally, at the end of the lecture, I think you must understand and think what is important, start applying what I'm telling you, and I think that is when you're going to learn. Thank you so much for the patient listening and for the opportunity to share my views. Thank you so much.
Thank you very much, sir, for the wonderful talk. We now invite Dr. Nair for his talk.
Thank you. Give me a moment while I share my screen. Is my screen visible and am I audible? Okay, right.
Good, sir.
Yes, sir.
Yeah, so this is the time of COVID pandemic, and today is World Thrombosis Day. So obviously, the topic has to be challenges in COVID coagulopathy. And Dr. Prabhakar set the tone of the background so well. I think there has been a real class for everything about thrombosis, antiplatelets, anticoagulants, updated right up to a week recent published articles. I think that was really fantastic. Enjoyed it. Thank you. Now, this is a data that came in, was published by Dr. W.H. Howell from Johns Hopkins, Baltimore in August 20, 1936. Oh, pretty old, 1936. 1936, this gentleman published the data saying something very unusual. He showed that the platelet count was much more in the pulmonary vein compared to pulmonary artery. Imagine that, how foolish. He said that he found that pulmonary venous blood contain more platelets than pulmonary artery. Now, everybody knows that platelets are manufactured in the bone marrow from megakaryocytes. So they come from bone marrow and circulate everywhere. Now, the moment you accept that pulmonary veins contain platelets more than pulmonary artery, it seems as if the lungs are manufacturing platelets. Lungs manufacturing platelets. In fact, that exactly is what this gentleman wanted to show, that the production of blood platelets in the lungs. He said that he believes a part of the platelets are produced in the lungs. You know, it looks like one of those messages that come in WhatsApp today and people immediately dismissed it. Go forward another 70 years and in 2010, people found that if you carefully section a lung tissue and stain it specifically, you see those red spots coming up. What are those red spots? They look like megakaryocytes. Megakaryocytes in the lungs manufacturing platelets. It turns out to be true, because as people proceeded in the last about 8 years and looked at the electron microscopic picture of lung tissue and looked into the interstitium, those green octopus-like stuff that you see there is nothing but megakaryocytes. So there are platelet manufacturing megakaryocytes, not just in bone marrow, but in the interstitium of the lungs. Yeah, lungs, true. And initially it looked very funny, but in the next couple of years, we did really find that there are megakaryocytes in the lungs. In fact, articles started coming in for the last about 3 years. For example, this is one article which talks about megakaryocytes in the lung, displays distinct transcriptional and phenotypic properties. Came this next article which talks about lung megakaryocytes are immune modulatory cells. But yes, people did accept that there are megakaryocytes in the lungs like the bone marrow, and they manufacture platelets. So this is new information. Lungs also manufacture platelets. In fact, if you look at those megakaryocytes in the lungs which manufacture platelets, looks like they do have some immune connection. As you see that particular slide, the stains is CD41, so looks like they have some connection with the immune modulatory system. Now, Now, let us stop that lung platelet manufacture business for a moment and look at our real villain today. Everybody knows what it is. It is the SARS-CoV virus. And we know that for the SARS-CoV virus to attach to the host cell, let us say the respiratory epithelium, which is the main attachment area of the SARS-CoV virus, it needs the spike protein. So the spike protein goes and attaches to the angiotensin convertase enzyme or ACE2 enzyme, and we know that how much of time we have spent talking about ACE inhibitors and all that. So ACE2 enzyme receptor gets attached to the spike protein of the SARS-CoV. But many often we forget that there is something else too. And that is something called TMPRSS2 or a transmembrane serine protease. Now the host cell to which the SARS-CoV gets attached needs to have a TMPRSS2, a transmembrane serine protein that has to activate the spike protein. So, you know, the host cell that attaches and nurtures and takes in the COVID virus needs not just an ACE2, but needs a TMPRSS2 or transmembrane special protease 2 to activate it. So you need TMPRSS2 and an ACE receptor to take the SARS-CoV virus inside. Now the point is many often we didn't understand that why, for example, a diabetic patient is more susceptible to SARS-CoV virus. Okay, we might think that he has less immunity, possible diabetic, less immunity, but it looked very funny. Till when we found that the expression of ACE2, the expression of that ACE2 receptor, which catches hold of that spike protein in the lungs, tend to increase with diabetes. So diabetes not just depresses immunity as general and makes the person susceptible to SARS-CoV, but increases the ACE2 receptor. Do you have proof? Yes, you have plenty of proof today. That is in normal lung tissue, and that red stain is ACE2 receptor. So you see, in diabetes, the epithelium of the alveoli becomes red because they express more ACE2. Not just the epithelium, but even the bronchial linings tend to express that orange stain that you see there. What is that orange stain? It is all because of stains received by the expression of ACE2. So in diabetes, patients are more susceptible to SARS-CoV because they express more of ACE2. So, you know, we have learned a lot. But what was very interesting is this. If you look at the TMPRSS2, not just the ACE2, the transmembrane serine protease that has to activate the spike protein for the COVID to get attached, you see that, oh, yeah, it is so interesting that, for example, the TMPRSS2 mRNA, if you look at lungs, it is huge. So no surprise that lungs gets affected so quickly in SARS-CoV. But in contrast, as cardiologists, we are happy to know that the heart is right there. Heart has very little of TMPRSS2, and that is why an actual clinical myocarditis is not very common. In fact, till about recently, we used to say that myocarditis is almost uncommon in COVID. Today, we know that they're common. If you apply the proper tool, for example, you do a cardiac MR, you find a lot of subclinical myocarditis, but the numbers are low because TMPRSS2 is significantly less in heart compared to lungs. Now, what are we looking at in SARS-CoV? We know that SARS-CoV virus tends to affect the respiratory system, create a small localized pneumonia, which in some people might just be like a respiratory infection and go away, or become a pneumonia, spread the entire lungs, create a ground glass appearance, the scoring may go up and might end up with a respiratory failure. So from just an upper respiratory infection to a significant pneumonia and respiratory failure, anything can occur with SARS-CoV. The other end of the spectrum, you have what we call as cytokine storm. We know that SARS-CoV virus creates an immune inflammatory response, whereby the epithelial inflammatory response is abnormal, and we have so much of a cytokine storm. Multiple organs are affected, the BP falls, the person goes in for a state of shock, a very bad state, cytokine storm. But today we are talking about something else, and that is hypercoagulable state. So apart from the respiratory failure, apart from the cytokine storm, we today know that, as Dr. Prabhakar has very elegantly shown, COVID virus creates a hypercoagulable state by altering everything that is shown. The Virtuous Triad, So it damages endothelium. So the carpet is damaged and frayed. You have abnormality of the platelet. You have abnormality of the coagulation cascade. So coagulation cascade is abnormal. Platelets are abnormal. The endothelium is abnormal. Along with that, you have hypotension. You are patient in bed rest, on ventilator. Stasis sets in. So remember, all the points of a venous embolism, venous thrombosis sets in. And that is why we get all these hypercoagulable problems. Now, a very interesting article came only about a couple of months back in JACC, which talks about anticoagulation, bleeding, mortality and pathology in hospitalized patients of COVID-19. This is from Mount Sinai Hospital, New York, where they looked into about 4,000 patients of COVID and looked into the group of people who got anticoagulation versus no anticoagulation. But first thing, they also took out patients who had died of COVID and looked into their autopsy. Look at that. That is a patient's lungs, where you see the microscopic vessels are filled with microthrombus. So small vessels in the lungs are filled up with small microthrombus. Large pulmonary vessels are filled with large clots. So COVID gives rise to microthrombi or large clots giving rise to pulmonary embolism. Right. But what surprised them was not just pulmonary. When they looked into the brain of people dying of COVID respiratory failure, they found that there were features of very clear small cerebral thromboembolism. Look at that, those red spots, cerebral thromboembolism. Okay, when they looked into the myocardial arteries, small myocardial arteries, they found that there are clots in the myocardial arteries. When they looked into the portal veins, they found those portal veins are clogged with clots. So portal vein, pulmonary artery, cerebral artery, coronary artery, everywhere you get clots. So we should spend 5 minutes on understanding what is absolutely new. This is absolutely new concept in clots. Before that, this particular paper in JACC that we are talking about very clearly showed that if you give anticoagulation, the y-axis is cumulative incidence of mortality. Mortality, death rate, right? And if you compare the black line on top as not received anticoagulation versus the bottom two lines, the red and the blue is prophylactic dose and therapeutic dose of anticoagulation, you see they are almost same, but those who received anticoagulation had a much better outcome with a lower mortality. But 50% lower mortality, right? It comes to about 20, the other one is 40. So significant lowering of mortality if you put patients on anticoagulants, whatever be your anticoagulants you think proper, NOACs or low molecular weight heparin. Now this is something very new, and I would ask you to concentrate because this is absolute new concept. That is COVID-19 vasculitis that came in a viewpoint in Lancet in January. Okay, now look at that. Now, when COVID affects lungs, let us say the COVID is mild, it can be mild. You see that red round only affected a small area as a pneumonitis in the lungs, right? So COVID can be mild or no lung disease. In contrast, COVID can be also severe disease. So COVID can be mild on the left and severe on the right. Now this mild tends to be, for example, if you look at age, in children or young people who are healthy, while the severe tends to come for older patients with multiple comorbidities like we showed, diabetes, hypertension, heart disease. Okay, so older patients, younger patients. But more interestingly, if you look at the blood vessels, okay, of this normal, the young people who get a mild disease, there tends to be the viral mRNA particles tend to be in the intima and media of the vessel wall. Okay, and very little inside the lumen. In contrast, if you look at people who are older, who got more diffuse disease, the intima and media are not much affected, but you see the lumen of the vessel is occluded. And on the left side, you see there is increase in interferon. On the right, there is decrease in type 1 interferon. Right. So the immune response is different. And not just that, in the young people, you have benign with recovery outcome. And in the elderly, you have mortality, increased mortality, pneumonia, bad outcome, multi-organ failure, and thrombosis. So today we know there's a clear difference between those who have mild disease, where the virus tends to be in the intima media, doesn't create an intra-arterial thrombus, while in those who die, there's a tendency for what you saw in that on those pathologic studies, multiple organ, multiple thrombus, right? But wait, there is even more, and this is it. Now the point is we can all understand, like Dr. Prabhakar has taught us, that in a patient who has infection, who is bed rest, stasis, there can be venous thrombus. And when this venous thrombus that is shown here in the diagram goes to the right atrium, right ventricle, it tends to go to the lungs. That is pulmonary embolism. So we know that deep vein thrombosis in the venous system, which comes in people who are sick, who are in bed rest, who are in ventilator, who are in sepsis, can go to the right heart and produce pulmonary embolism. Okay, so we knew that there is a deep vein immunothrombosis and embolism. But what we did not understand was, why was there so much of systemic thromboembolism? Right, and the answer is here. In the lung small vessel, there tends to be small blood clots. In the lung blood vessels, there tends to be small blood clots. They, independent of the right-sided affair, go through the pulmonary vein, and then they go on to the systemic circuit. They go to the left atrium, left ventricle, systemic circuit, go to brain, go to kidneys, and go even to the skin. So in fact, it is said that if you have a small vasculitis like the skin lesion, you take it out and you would see exactly like a vasculitis, where small multiple thrombus might be in the small arteries under the skin, which is typical of the cutaneous features of COVID-19 if you look under the microscope. So the point is, the source of the systemic embolism is not venous, obviously, and they are from the lungs. Lungs? I think you remember that we started with somebody thinking that there might be a source of platelet in the lungs. Yes, we are coming to that. So today we know that this article in Lancet very clearly shows that if we are looking into the small pulmonary vessels where the resident megakaryocytes in the lung produce platelets, they get into the system, and as you have learned, they have an immunomodulatory nature, and they gradually migrate onto the system. But the point is, this is exactly like the venous thrombus and the arterial thrombus difference that Dr. Prabhakar has shown. This is different. The clot in COVID is immunothrombotic clot that you see on the left, compared to the usual fibrin clot that you have learned on the right. So the immunothrombotic clot that forms primarily in the small vessels of the lungs tend to come to the left atrium, left ventricle, and goes to all the organs, including brain, including peripheries, including kidneys, everywhere. So the mechanism of DVT, pulmonary embolism, is different. While in COVID, the reason for systemic microembolism is different. They look like they come right from the lung, because it is the lungs that tends to primarily get affected by COVID. And this is an absolute new concept. So now we are trying out newer therapies directed at this concept somehow to stop coagulation. Okay, but let us say common things. Common COVID thrombosis that I would see or you would see would be DVT, a pulmonary embolism, right side. And of course, ACS and STEMI, you can have CVA or you can have venous sinus thrombosis. Those 1, 2, 3, 4, 5 are the commonest types of thrombus that we would see in clinical setting. DVT, pulmonary embolism, ACS, STEMI, CVA, and venous sinus thrombosis in the background of COVID-19. And what do? We can give antiplatelets. We have learned already about all that from Dr. Prabhakar, low molecular weight heparin, VK and warfarin, and of course, the NOACs. Now, the point is that one thing, see, despite all this theoretical knowledge of megakaryocyte lungs, looks interesting, but when this is a real challenge. In clinical medicine, a patient who is sick, he may be on ventilator because of respiratory failure. He may already be in hypotension because he has cytokine storm. When do I suspect Thrombembolism? Right? A patient who was fine suddenly comes with an acute breathlessness. His ECG shows an S1Q3T3. Anybody would diagnose Thrombembolism, right? But how do we diagnose Thrombembolism or suspect in this setting? One, worsening hypoxia. When your patient's hypoxia worsens without any clear notice, take a CTPA and rule out Thrombembolism. Unexplained drop of blood pressure in a patient of COVID. Unexplained tachycardia. Very high D-dimer, sudden jump of D-dimer, and probably an increased alveolar arterial oxygen difference. This is something that we always tell our students, and many people don't seem to care. And those who care always seem that this is a very complex pathophysiology. How can I understand as a clinician? It's not so, as I will show you just now. See, the alveolar arterial oxygen difference is the oxygen difference between the alveoli and what is in the arterial system getting absorbed. How it is calculated is simple. The formula is 150 minus PCO2 into 1.25. Very simple. Okay, so the alveolar oxygen is calculated with this formula. So, and then once you get an alveolar oxygen, so 150 minus PCO2 into 1.25 from your ABG. And once you get the alveolar oxygen, you have your PO2 also in the ABG. So alveolar oxygen and the PO2. From alveolar, you minus PO2. And if the normal range should be less than 20, or the other calculation is age by 4 plus 4. So age is 60, 60 by 4 is 15, plus 4, 19. Okay, so normal AA is less than 20. If it is more than 20, suspect there may be Thrombembolism. Let us take an example and make it simple so that you won't forget it, right? Let us say the patient's PCO2 is 40 into 1.25. How much it is? 40 plus into 1.25, 50, right? So 150, so 50. 150 minus 50 gives you 100. So, you know, this patient's alveolar oxygen is 100. Alveolar oxygen is 100. And you take the ABG report and see that the PO2 is what? 80, let's say 80. Okay, so you say, okay, or 80 or 90, it's wrongly put as 80, let's say 90. So 100 minus 90 or 80 is 10 or 20. That is alveolar arterial difference. So if it is 90, it is 10, it is normal, there is no Thrombembolism. Now understand, this is not a very sensitive sign. Neither is it very specific for Thrombembolism. But in a patient who has a worsening hypoxia or unexplained blood pressure drop, you're suspecting this helps. So a unexplained increase in alveolar arterial oxygen difference calculated by this formula tells you that there might be a Thrombembolism. Now, who has a high risk for Thrombembolism? I mean, thromboembolic problems in COVID? One, a background patient. A patient who has come with COVID who is already bed-bound, unable to walk, previous VT, P, AF, cancer, obesity. These are patients who are already susceptible to clots, right? So they are high risk. Second would be a group of people who come during COVID. During COVID time, they came with established VT, venous thromboembolism, or a Thrombembolism. Or somebody who has got a multi-organ failure, long ICU stay, ventilator, and a very high D-dimer. These are patients who we know that they are sick. So either patient has a background which is bad, bed-bound, previous VT, embolism, AF, cancer, obesity, or had a very bad course during COVID, or post-COVID, the person is immobilized. He is so weak, he can't walk. So post-COVID immobilization, pre-COVID, there are multiple problems. Or during COVID, their hospital course was bad. These are patients who are in high risk for thromboembolism, and they should receive thromboprophylaxis and discharge. How long? At least 4 to 6 weeks. Depends on the background, and you might be guided by a D-dimer. Now, COVID thrombotic complications, there is no universally accepted guideline. And the only guideline that is good is credited to Dr. Prabhakar. I mean, his group, they put it out. This is called the Tamil Nadu government scientific position statement. I think it is very good, but I think everybody says it's TLDR. TLDR is what? Too long didn't read. Too long didn't read. So let us make it simple. Just revise it quickly. So if you have mild, or if your patient has mild or moderate COVID, definition is there in the algorithm, look at the bleeding risk. Mild moderate COVID, look at bleeding risk. If the bleeding risk is high, no anticoagulation. If the bleeding risk is low, obviously they receive anticoagulation, whatever be the dose, that's different. So mild moderate COVID, bleeding risk. Bleeding risk high, no anticoagulation. Bleeding risk low, give anticoagulation. In contrast, if the severe or critical COVID, they will anyway receive anticoagulation, whatever the dose may be. And very clear is prophylactic doses, enoxaparin 40 milligrams daily, unfractionated heparin 5,000 units subcutaneous daily, or apixaban 2.5 BID, rivaroxaban 10 milligrams once daily, low dose. The intermediate doses in between, and therapeutic dose is high dose. So what is therapeutic dose? Enoxaparin 60 milligram BD is standard dose, right? Or unfractionated heparin with a target APGT of 70 to 110, or full dose of apixaban 5 BID, rivaroxaban 10 milligram BID. And intermediate is in between. So you decide the dose and give your patient the dose. So couple of tips and tricks which always we are asked in the absence of active bleeding. Abnormal PT is not a contraindication for low molecular weight heparin. PT may be abnormal. The patient has no bleeding. You can still give low molecular weight heparin during active COVID period. Stop low molecular weight heparin only if the platelet count is less than 50,000. This is in the absence of bleeding. And stop LMWH only if fibrinogen is less than 0.5 in the absence of bleeding. So very low fibrinogen, very low platelet count, you should stop LMWH, but not unless it is associated with bleeding. If there's bleeding, you stop much earlier. No bleeding, you can wait till 50,000 platelet count, 0.5 grams of fibrinogen, and an abnormal PT is not a contraindication for low molecular weight heparin. No at dosage. High dose is, of course, for patients who are in VT, patient who had an EVT or a PE or a 6 times higher D dimer, give them high dose. Patients low dose those are prevention. They didn't have a VT, didn't have a PE, and had lower D dimer, give them a preventive dose of noise. Because this is often asked what dose we should give. The dosage again varies from institution to institution. Most people's high dose is 15 milligram BID for 3 weeks, then 20 milligrams OD of rivaroxaban, or apixaban of 5 BID, or a dabigatran of 150 BID. And low dose is rivaroxaban 10 or 15 milligrams, or apixaban 2.5 milligram BID, or dabigatran 110 BID. But again, varies from institution to institution for COVID. Our usual practice is high dose is 10 milligram BID of rivaroxaban, and 10 milligram OD of rivaroxaban is the low dose. That is our institution policy, but I leave it on to you depending on what you want to do. How long? 4 to 6 weeks is generally recommended. This is all single center or smaller experiences. No guideline says how long to give. It depends on your individual assessment of the patient risk, right? Generally, we give for 4 to 6 weeks. You can extend it if the patient had bad and you think that they have a higher chance of problem. At the end, I think we should look at that Chinese word. It's called Wei Shi. Wei Shi in Chinese means crisis. Crisis. Pandemic is a crisis, right? But crisis word in Chinese has 2 distinct letters. The first letter means danger. And the second letter, surprisingly, means opportunity. So in crisis, there is danger and opportunity. And that leads us to what we say is that, yes, we are going through a bad time, but we all believe that, yes, we can do this, right? We will win. And already we are winning. COVID is going out. And like Winston Churchill once said, don't let a good crisis go waste. Don't let a good crisis go waste. Thank you for your time and attention. I will give back the podium to the organizers.
Thank you very much, sir, for the wonderful talk. We now hand over the session to Dr. Prajapati for his talk.
Yeah, good evening all the panelists and respected Dr. Nair sir, Prabhakar sir, and let me share my screen. And good evening to all the doctors in the audience across the India. Uh, I will not take more than 15 minutes because some of the slides are covered very well by Prabhakar sir. And the today's topic is NOAC need to understand in a better way, rather than I can change my topic to need to apply in a better way after the last slide of Prabhakar sir. So it is better to understand, and rather it is more better you apply those technology or drugs to your patients for a good clinical outcome. So the key points to know before prescribing NOACs are the indication, correct indication and selection for its use. So first is non-valvular atrial fibrillation, DVT, pulmonary embolism, chronic coronary artery disease, and peripheral artery disease. And of course, in the recent days, as Nair sir described very nicely, COVID coagulopathy and this LV thrombus, which is off-label indication. Another thing to look before prescribing is the patient's age and weight, definitely for deciding the dose, renal function, liver function, patients taking other drugs, that is interacting drugs. Then we have to weigh with the risk of stroke versus risk of bleeding and the periodic assessment. So this is the heart of the presentation. So if we focus on all the areas, then most of the time we can very well manage our patient, and we can be safely prescribing the NOACs, and the complication rate like bleeding and breakthrough thrombosis will be less. So what is the ideal anticoagulation? I think if we compare the multiple drugs like LMWH, unfractionated heparins, VK, and NOAC, the NOAC scores better amongst all these drugs, like overall availability, no significant food drug interaction, predictable response, no requirement for coagulation monitoring, fixed dosing, and no hit, cost, and reversible. So not all are reversible, but we have drugs which we can reverse the NOAC effect. So as Dr. Prabhakar sir described, I am not going in detail of the pharmacokinetic, but as he rightly said, the important thing is food effect, which affect the warfarin absorption, like high vitamin K food. Dabigatran, there is no food interaction, but if patient is having acid peptic disease, and definitely we can think of that there is some irritation, GI irritation. Rivaroxaban, definitely 20 and 15 milligram doses to be taken with food, and there is no food interaction with apixaban. Similarly, the important thing is looking towards the renal clearance, which is less with warfarin, then 27% with apixaban, then comes rivaroxaban and dabigatran. So patient with the CKD and very low GFR, definitely we should prefer warfarin or apixaban, or at the most rivaroxaban, and definitely we can see the GFR and regularly monitor the patient for the dose and the alter in renal function. So this is very important. Now, I think these all are covered. Dabigatran, which is reversible, potent, competitive inhibitors, and it affect the clot and free inhibit free and clot bound thrombin, and it block the thrombin, induce this activation of coagulation factors as well as platelet. Now coming to approach in one by one different indications, like in non-valvular AF, the first thing is to decide the proper risk of the patient. So that is to be done by CHATS-2 score and Hasbled score. So this is one flow chart from 2020 in ESC guideline. So when patient comes with atrial fibrillation, first you rule out that it is not a valvular atrial fibrillation. That is the AF with prosthetic mechanical valves or moderate to severe mitral stenosis. That is mainly rheumatic mitral stenosis. So if it is there, then you can give VK with high time in therapeutic range. If it is not there, then it is where do you calculate the risk. If it is CHATS-2 score 0 in male and 1 in female, then there is no need of anticoagulants. You can manage on aspirin 75 to 325 mg. Then if it is CHATS-2 score more than or equal to 1 in male or more than or equal to 2 in female, then you calculate, obviously calculate Hasbled score. And if it is more than 3, then it indicates that you have to be very vigilant and you have to be very careful in monitoring the patients regarding bleeding. If it is 1 in male and 2 in female, then it's a class 2A indication. You may continue with oral anticoagulation or aspirin, and it's a class 1 for more chest to VAS score more or equal to 2 in male and more or equal to 3 in female. So this is just the approach. Now, a specific group, as Prabhakar sir discussed, AF with PCI. This is a 60-year-old male patient with AF, CAD, and diabetic requiring PCI. So, what the statistics says, the concomitant AF and CAD is a common due to the strong association of both the condition with aging and overlapping risk factors. CAD is estimated to occur in 20 to 45% of the patient with AF. The literature indicates that the 20 to 45% of the patient with AF and CAD require the coronary artery revascularization by PCI or CABG. And in a prospective study, almost 34% of the patients with AF also had CAD, of whom 21% require PCI or CABG. So it's a large number of patients to whom we are coming across with this type of situation. So this is the same as sir described, that in ACS situation, when we are going ahead with PCI on background of anticoagulation, we can continue aspirin for up to 1 month and P2Y12 up to 12 months in ACS situation. And in chronic coronary syndrome, we can continue anticoagulation for long term and P2Y12 for 6 months and aspirin for 1 month. So regarding aspirin for 1 month, it's all depend on operator, which type of stent, mostly drug-eluting stent we kept, but at which place, like if we have kept in LMCA, that it's an individual variation, but it's a general guideline. Most of the patient we can follow with this, but at every point of time, we have to monitor the bleeding versus thrombotic risk, and we have to decide accordingly. Another case, 76-year-old female with atrial fibrillation, hypertension, hypothyroid, and having creatinine of 38 ml, creatinine clearance of 38 ml per minute. So in each and every patient, you have to calculate the creatinine clearance, and if it is abnormal, then frequently you have to monitor. So the multiple main three anticoagulant, NOACs, rivaroxaban, we have 3 doses, less than 15, it is not recommended. For 15 to 49, 15 mgOD, and more than 15, 20 mgOD. Similarly, apixaban, it is less than 15, not recommended. Between 15 to 29, low dose. More than 13, as previously discussed, age more than 18, weight less than 16, and creatine more than 1.5 milligram per deciliter. If more than 2 criteria, low dose, and otherwise a full dose. Similarly, dabigatran, we are having this type of dose tailoring depending on age of the patient and creatinine clearance. So the age, creatinine clearance, weight, everything is very important while prescribing the NOAC. The guideline says the renal and hepatic function should be evaluated before initiation of NOAC and should be reevaluated at least annually. If it is abnormal, then I think very frequently, maybe 3 monthly, or depending on patient's clinical condition, we have to change. Not going in detail of DVT, PE, but one thing just I would like to focus that in a treatment DVT, PE, the first part of initial management of this DVT, PE, we have option of definitely heparin, low molecular weight heparin for the perinox, but we have 2 anticoagulants, NOACs, which can be started from day 1 only. Those are rivaroxaban, apixaban. These are the drugs which do not require overlap with low molecular weight heparin or heparin. So which we can start from day 1 compared to dabigatran, which requires the overlapping with heparin and low molecular weight heparin. So this is the one point that I would like to focus. These all various trials that already discussed by sir. This is the same slide. The chronic coronary syndrome patients, the chronic coronary syndrome patient receiving single antiplatelet and patient with MI after completing DAPT, that is usually more than 1 year. Then how will you approach ahead the antiplatelet and antithrombotic? How will you see? So first you look for the high risk features of bleeding. These are the multiple features that were discussed previously. If these are there, then you continue single antiplatelet. Then you see additional risk factors like PAD, multivessel coronary artery disease, and enhancing risk factors like chronic heart failure, CKD, diabetes, and recurrent MI. If it is not there, then you can continue single. If it is there, and along with the ischemic stroke, then you can go with dual pathway inhibition with low dose aspirin less than or equal to 100 mg with rivaroxaban 2.5 mg BID. If chronic coronary syndrome with previous MI, you have two options with DPI, and another option is low dose aspirin with 16 mg ticagrelor BID, but definitely at the cost of slightly higher bleeding. And the third is CCS without previous MI. You have option of DPI dual pathway inhibition. So this is in nutshell chronic coronary syndrome with high risk features. You can have rivaroxaban as a therapy. This is also, these are very well discussed, like in high thrombotic and bleeding risk. High thrombotic, low bleeding risk, we have dabigatran is a powerful agent. Low thrombotic and high bleeding risk, the first choice is apixaban. Moderate thrombotic and bleeding risk, the first choice is apixaban, dabigatran low dose. And high thrombotic and high bleeding risk, we can choose apixaban over other drugs. Compliance issue, rivaroxaban, and moderate renal function, apixaban. So these are some general guidelines we can follow. Now the main concern is the bleeding. So what are the bleeding risk factors for the patients who are having antiplatelets and anticoagulation for longer period of time? So these are the age more than 65, age more than 75, previous bleeding, cancer, metastatic cancer, renal liver disease, thrombocytopenia, and so on. So depending on the number of risk factors, we have low, moderate, and high risk of categories, and then you can judge the duration of this anticoagulation therapy. Now, these are some guidelines regarding to avoid bleeding complication, especially when we combine antiplatelets and anticoagulants. So definitely assess the ischemic and bleeding risk using validated risk predictor like CHETS2 and Hasbled score. The keep triple antiplatelet therapy, triple antithrombotic therapy for short duration, dual therapy after PCI to be considered instead of triple therapy, depending on the risk, ischemic versus bleeding risk. Consider use of NOAC instead of VK when NOACs are not contraindicated. When you are using VK, so target INR is lower part of the recommended target range and maximize time in therapeutic range, more than 65 to 70% when VK are used. Consider the lower NOAC regimen tested in approval study and apply other NOAC regimen based on the drug specific criteria for drug accumulation. When using this anticoagulation, you can use clopidogrel as a better choice to prevent bleeding. Use aspirin as low dose less than or equal to 100 mg and routine use of PPI to prevent GI bleed. Another thing, we have the two antidotes like idarucizumab, which is recommended for reversal of dabigatran for the life-threatening bleeding and an urgent procedure, and endaxanate alpha for the reversal of factor Xa inhibitors. But I think the availability of this antidote of factor Xa is slightly difficult, but this dabigatran antidote is available. Now, this is just a general guideline regarding severity of bleeding and what to do. So when patient is coming with active bleeding on anticoagulation, the compress the bleeding site mechanically, routine assess the hemodynamic status, blood pressure, basic coagulation parameter, blood count, kidney function, and then you see which type of the drug he is receiving. So VK versus NOAC. So we are just discussing about NOAC. So you see the severity. If it is minor, then you delay NOAC for 1 dose or 1 day. If it is moderate to severe, then you add symptomatic treatment like fluid or blood replacement, treat the bleeding cause like GI bleed, you do gastroscopy. And if it is considered to add charcoal, if it is recently ingested this NOAC. If it is severe or life-threatening, then you definitely consider to use the specific antidote, then PCC if no antidote is available, and replacement of platelet if at all required. The dose selection criteria definitely covered multiple times. Another important thing is drug interaction. So every time when patient is coming to you, you see that anything, if you are not seeing the predictable effect or you are seeing some side effects, see for the interacting drug. Like for dabigatran, the things which increase the anticoagulation effect are amiodarone, verapamil. So definitely these are the common drug which we can use, which we use. Then other are tacrolimus, cyclosporin, and HIV protease inhibitor, dronedarone. Similarly, rivaroxaban and apixaban, azoles, antimycotics, HIV protease inhibitor, and dronedarone. If the desirable effect is not there, then you see for rifampicin, carbamazepine, phenytoin, phenobarbital, and St. George's wort. So these are the few drugs which we can use, we are using commonly, and then we can see the interaction. So at last, the important checklist when patient is coming, mainly we should see for adherence for the drugs, then signs of thromboembolism, signs, symptoms of bleeding, side effects of anticoagulations, co-medications, blood samples for hemoglobin. As Sir rightly said, anemia is very important predictor of bleeding, renal, liver functions, then assessing and minimizing the modified risk factor for bleeding. This is also important. Patient is taking NSAID, patient is not, hypertension is not well controlled. So all these things, small things we have to see in each follow-up, and we have to rectify it. And the last and final most important is whether the chosen NOAC is the best for the patient and the chosen dose is correct or not. So if we monitor and see all these things, so there are less chances of breakthrough, stroke, and bleeding. So this is in nutshell the overview of the indications and how we will prescribe and monitor anticoagulations, NOACs. Thank you so much.
Thank you very much, Dr. Prajapati, for the
Thanks.
Wonderful, very simple and very progressive talk. Sirs, we now go to the Q&A sessions. The first question we have is for Dr. Nair, sir. Sir, considering that patients may have a very good alveolar reserve, and as shown by you from the Lancet publication, patients might have microthrombi in small section of the lung, but might not have a drop in SpO2. So should a 6-minute walk test become a norm for all OPD patients of COVID-19?
Yeah, I think so. See, despite not having studies, I think this is one of the major tests where very early problem in alveolar ventilation can be picked up by 6-minute walk test. In fact, initially when the reports came, we were all skeptic. What is this 6-minute walk test? And then came a time when we all tell our intelligent patients at home that you do a 6-minute walk test. Only we have to very clearly tell them how to do that. We have to tell them that first check your SpO2 and then take away the SpO2, the probe, and keep it aside, and then start walking. And walk at usual pace. Don't increase your pace. Okay. And walk for 6 minutes. If possible, the length should be maximum. Don't walk in a very small room so that you can every time turn. And then at the end of 6 minutes, you put the SpO2 meter again and see what is your saturation. If the saturation has dropped below by more than 5, or it has fallen below 94, then it is an indication that there may be a very early interstitial edema. Unfortunately, studies have shown that it is not the micro thrombi that is predicted by 6-minute walk test. What 6-minute walk test actually predicts is a very early pneumonia. We know that in COVID, the pneumonia is mostly interstitial to start with. And that early interstitial edema, just like our interstitial pulmonary edema, that is picked up by a 6-minute walk test. I think 6-minute walk test is very good as long as you know how to do it. And you are confidently, you can teach your intelligent patient to do it, it can do. So whichever of our close relatives had, we had all advised them to do a 6-minute walk test and report back. If there was a defect, you come to the hospital and report back. I think it is very good.
Thank you, sir. The next question we have is for Dr. Prajapati. So this might be a little off topic, but considering thrombosis, Angina with normal coronaries, what are the other things we need to consider other than thrombosis? Angina with normal coronaries.
See, angina with normal coronaries are these are the very well established entity, and definitely we have to see that is microvascular dysfunction. It's a maybe a endothelial dysfunction, or there is microvascular atherosclerosis coronary artery disease that we term as microvascular angina. There are other causes like severe hypertrophic cardiomyopathy, severe left ventricular hypertrophy. These are the other causes where there is a microcirculatory level. The patient is ischemic. So the epicardial coronaries are normal, but still patient is having angina. So we have to think at microcirculatory level. So it's either endothelial dysfunction or it's a microcirculatory problem. It's a atherosclerosis or the tone of the microcirculation is changing because of all these things. So these are the other examples of this vascular angina. And it is very common.
Yeah, I think this is very important, and Dr. Prajapati has highlighted it very well. I mean, for the physicians at large to understand that you have to shift your focus from obstructive coronary. Okay, especially today, if you see a lady, 50% of ladies would have maybe a coronary angiogram, normal coronary angiogram with angina. Okay, and so if the physician goes and tells them that your coronary artery is normal and it is all functional, you have your psychological problem and go home and take an NSAID, they're wrong, right? So we should understand the pathophysiology very clearly highlighted, and I think it is important. So understand that there may be either dynamic obstruction, like a coronary spasm, which you do an angiogram, it may be normal, or the epicardial coronary artery is normal, everything may be in the periphery. Or you have some kind of deposition disease, right? For example, a severe left ventricular hypertrophy or an infiltrative disease where the small vessels are unable to relax during exercise. So you might get angina. So no point in telling them that you don't have angina, you go home, rather than try to understand the pathophysiology and treat them properly. I think, thank you. It was a very apt question and a very nice answer.
Thank you, sister.
Yeah, please.
The third question we have is for Dr.
No,
Dureraj.
wait.
No, beautiful question.
Prabhakar wants to tell something.
Yeah, I'll
yes.
add one more point to
Yes,
that.
please.
Two wonderful things. 2 points I want to add to this. One is it's definitely microvascular dysfunction. Couple of clues to microvascular dysfunction. When you do a treadmill test and the treadmill test is positive and the recovery changes are more, and if your treadmill is positive because of the recovery changes, angiogram is normal, it most probably requires microvascular dysfunction. It's a small clue to what happens. And you treat them like angina, treat them with beta blockers, statins, and ACE inhibitor. These three are pretty effective. You have to treat them, but the problem is if there is a persistent angina or what these question has been asked, it is actually a poor prognostic indicator. That also you must understand.
Dr. Dureraj, the next question is for you. You had mentioned about this dual pathway inhibition. So aspirin plus low dose rivaroxaban, 2.5 milligram. What patients would you want to consider in and when?
That's a very tricky question. But my first indication for aspirin with 2.5 twice a day is the one with peripheral vascular disease. Because the one clear indication where there is a clear benefit, loss of limb and loss of the amputation and all those things come down is with peripheral vascular disease. Therein definitely rivaroxaban 2.5 twice a day works. But additionally, all those patients with diabetes and multivascular disease and all those high-risk patients that I mentioned about, those with recurrent myocardial infarction, multivascular disease and diabetes and chronic kidney disease and maybe even heart failure, they all benefit. But what I used clinically is I used a very high index because the incidence of bleed is very high. The number needed to treat and number needed to harm are more or less similar. So you have to choose your patients very carefully. You can't keep using it. The industry has gone gaga and go over 2.5 milligram twice a day because it's available. It's off patent. But I think you must use your clinical discretion and clearly understand that those patients who are maximum benefit are those with peripheral vascular disease, multiple risk factors like recurrent myocardial infarction, diabetes, heart failure, chronic kidney disease. Those patients, I think you can use rivaroxaban 2.5 twice a day. But otherwise, I think you should go for a high intensity statin prevention, probably the other dual antiplatelet. If you want to look at dual antiplatelet therapy, the safest dual antiplatelet therapy is still aspirin and clopidogrel today. Tiny sir, anything you want to add?
Yeah, absolutely. Fully agree with you. And I think people tend to lose focus on this 2.45 BID. What we have learned from the trial, more important for me, would be that, see, all these years when we see a coronary artery disease patient, how do we assess his risk? Okay, we would say that how many risk factors he has, diabetic, hypertensive, more, okay, more risk. We used to see how bad is the coronary arteries, single vessel, discrete, no, double vessel, triple vessel, diffuse disease, okay, 2. Number 3, we used to look at his LV function. And number 4, we used to look at how far is he from an acute event. See, 3 months within an event, oh, he's bad. Oh, 2 years back he had an event, he's fine, he's good. So distance from time from the event, distribution of his coronary artery disease pattern, LV function, and the number of risk factors. That used to be the standard guide. But after this trial, we have learned that polyvascular disease is so important. Okay, as a cardiologist, I will look only at the heart. Somebody will look only at the periphery. Somebody will look only at the... And if you look at all the large registries, you see that most polyvascular disease, 40% of them will have a peripheral vascular disease. And residents who have worked with us very clearly know that they will get a real scolding if they have not started examining from the peripheral pulse in our clinic. In those who work with me, they know that first we start examining by the peripheral pulse. If you are working with me and you not tell the posterior tibial and dorsal ischiatus and not ask the patient about claudication, you learn that this is wrong. So they all learn. And the advantage is you are picking up a person with a much higher risk. And exactly like Dr. Prabhakar said, the area where it has made a difference is peripheral vascular disease. So if you see somebody with a peripheral vascular disease, he is likely to have a polyvascular disease. And that person with a polyvascular disease is one where if he has multiple events, you should think that would he do better with a dual pathway inhibition rather than antiplatelet. It is not individual. And very clearly, Dr. Prabhakar showed you that slide as to whom would it work best.
Yes, the next question is for Dr. Prajapati. So you have already shown this in your slide, but nevertheless, an important question. Dabigatran, as you had shown, has a reversal agent, idarosizumab, and both rivaroxaban and apixaban, though not available in India, do have a reversible agent and an exit alpha. So the question asked is, if any patient develops bleeding complications on NOAC, does it just make clinical sense to use FFP instead? Only fresh frozen plasma.
See, I am not a hematologist or not a specialist in hematology. So definitely, whenever I come across, this is what I think and I practice. Touchwood, I am not coming across majority of the patients with the bleeding and NOAC, but definitely I would involve a hematologist and then go ahead. That is the answer.
I'll add something
I
to
think,
that.
yeah.
Go ahead,
One
sir.
thing we should all understand that even your praxibind or andexet alpha is not indicated for an NOAC-induced bleeding. Understand, they are not. These agents are indicated. Suppose you have a patient on NOAC and you are just given one dose and you urgently need to do a surgery for the central nervous system. Okay, and neurosurgery is immediately needed. He has a bleed inside his head and he's going to cone and die. You want to do an immediate neurosurgery, and he has just taken 2 hours back a dose of maybe dabigatran or rivaroxaban, depending, you might give him praxibind or whatever. But just for a person who has a bleeding, it is not an indication to give a praxibind or andexet alpha. Okay, because these are short-acting agents. The moment you stop them, within 12 hours, the agent is out, right? Number one. And second is FFP, there is no indication, very clear, don't use FFP. If you should use PCC, right? That is the clear indication. Everybody clearly says that don't use an FFP, use a PCC, but mostly you just wait, your bleeding will subside, right? Naturally. Yeah.
But the point I wanted to add was simple. I think Dr. Tiny beat me to most of what I wanted to say, but couple of things. Most of the patients, by the time they come to you, if it is a dabigatran-induced bleed, we have only praxibind. If your APTT is normal, then you really don't have to use praxibind. That is one thing you must understand clinically. Second thing is, in India there are about 4 or 5 centers. They had 4 cases totally in the entire study. They didn't have cases because they didn't have requirement for using Praxibine, though it was free, part of the trial. So actual requirement of the reversal agent is very, very, very less. I just want to stress that it is hardly anything required, because by the time the patient comes to you, he's already bled out of the window. APTT is normal, because APTT is a very good bind for the dabigatran. With a normal APTT, patients don't bleed. With a high APTT, probably you can start using Praxibine, but otherwise no. But clearly understand APTT is useful in that.
Thank you, sir. Thank you for the same. The next question goes to Dr. Duvairaj. Sir, dabigatran versus apixaban versus rivaroxaban. How do you place each in clinical practice?
Remember, there was a book called First Among the Equals by Jeffrey Archer. More or less puts me like that, because I actually gave an answer to that in my slides, looking at what is the risk factors. Now, I think one of the biggest advantages is apixaban has got a clear indication for a lower dosage. Age more than 80, weight less than 60, and a creatinine 1.5. If you have 2 of these factors, you can use 2.5 or less. Lowest incidence of bleed. Wherever you expect a high incidence of bleed, probably apixaban is best. Wherever you expect the risk of stroke to be high, the most powerful or the best anticoagulant seems to be 150 milligram twice a day of dabigatran. So I think that has to be used. But in real world studies, it has been quite different. Rivaroxaban, though they say the bleed is very high, there are a lot of problems, because they say that the Charge-Wasp score was higher in the Rocket trial and all those things. But still, practically, rivaroxaban is also useful because it has a lot of multiple advantages. Once a day dosage, compliance is better, and patients definitely do take it. But remember, rivaroxaban, the bioavailability is less and it has to be taken with food. There are some other advantages of rivaroxaban. Rivaroxaban can be given through the Ryle's tube. You can crush it and give it. You can't give dabigatran. Dabigatran has to be mixed with tartarate, and you cannot crush the tablet and give it through a Ryle's tube. So if you want to give it, you have to give it orally. The GI side effects are very high, especially with the generics. The generics, the GI side effects are much, much higher because they have not got the combination right. And I'm talking more scientifically here, but you must understand, but that is how it is. And I think each one has its gone. My practical usage, I don't know whether others beg to differ. I'll probably like to take the opinion of Dr. Prajapati and Dr. Nair on this. My usage is high risk, younger patient with risk for a stroke with atrial fibrillation, I use dabigatran. Older patient where there is a risk of bleed, I use apixaban. For a venous thromboembolism, 100% I use only rivaroxaban. This is a very simple guideline which I use. Dr. Prajapati and Dr. Nair, I think I want your opinion too.
I really agree, with that, what you said, that people who have got maybe a stroke while on an anticoagulant and you want to go for the best possible prevention, it is 150 BID of dabigatran, no doubt about it. And the person you would want that is very fragile, you want the lowest of the dose that would cause the least bleeding is 2.5 BID of apixaban. These two extremes are very clear. The rest of it, there is no data. It's all individual. In fact, we have been asking Dr. Fox about what is his opinion. He said, give Fox and see, whichever one you are comfortable with, write it. We said about GFR, whichever you are comfortable, write it. Don't write dabigatran because it is mostly through kidneys. Rest of it is your experience, because he said there's no head-to-head trial. As long as you give it, it's going to be good. And our usage of rivaroxaban is huge. So people who are not in these extremes, very high risk of bleeding or the very high risk of thromboembolism, they all get rivaroxaban. The advantage of rivaroxaban is that you have 20, you have 15, you have 10 BD, you have 2.5 BD, depending on whether you are looking at chronic coronary disease or AFib or whatever it is. Now the point is, if there is one message to the number of people who are listening, physicians, do not give 2.5 BID of rivaroxaban for AFib. It has no effect, right? You still cause bleeding and not prevent your AFib-induced thromboembolism. It's purely for chronic coronary artery disease. Use it only for chronic coronary artery disease. If you want to use for AFib, you have to use the AFib dose.
Thank you, sir.
You promised that
Just
9:30.
sure, sir. Just a few more interesting questions, if we can quickly take, sir. 3 of them. The next question to Dr. Nair. Sir, considering, so you had mentioned about COVID-19 role of NOACs, and you also had mentioned a duration of up to 6 weeks, and a D-dimer above 6 times of normal. Beyond that, once NOACs are started, is there something that we need to monitor after starting NOACs? Even after 6 weeks, if the D-dimer is high, but the patient is mobile, active, has a normal saturation, and is otherwise completely normal, should we continue the NOACs or should we stop?
The answer is we have no data. It is purely anecdotal and your personal decision, because with all this, when the action trial came out, it showed that rivaroxaban didn't do any good to patients who were discharged on rivaroxaban post-COVID, right? So we have no data basically. So it all depends on, my take could be that a patient who, as I have shown the list, whom I would write high risk, right? He is discharged 6 weeks later, he comes back, he is fine, his D-dimer is normal, I'll stop it. His D-dimer is very high, or he still says he is unable to move out of home, he's always bedridden, he already says that 3 years back he had a cancer surgery, he's obese, I would still continue for maybe a couple of weeks. There's no data. See, because I can always tell you that, okay, at the end of 6 weeks, his D-dimer is high, give for another 2 weeks and then stop. Do I have a valid reason to say that? No, it is my own impression. So general tendency, general logic could be very high risk, start them on discharge, 4 to 6 weeks, recheck their clinical status. Clinical status is fine, D-dimer is normal, stop them. Clinical status is abnormal or D-dimer is high, you are free to continue. Again, it depends on the bleeding risk, right? 80-year-old person is likely to bleed, we will all say don't give rivaroxaban. A person who is maybe 30 years old and a bad COVID and has a D-dimer, little bit elevated, we'll say you take it for another 2 weeks and come back with a D-dimer. It is all anecdotal. There is no background for this kind of recommendation, but we do go by our logic and the present state of knowledge that we have.
I'll add one more point to that. The one point about the D-dimer is actually an indicator of the severity of the disease, and it is not an indication for anticoagulation. One of the things that Dr. Tiny had said also, I think it was very clear. D-dimer is not an indication for anticoagulation. That also you must understand. It's a purely clinical judgment, and what you have to do. I think that message Dr. Tiny made it very, very clear.
The last question of the day to Dr. Dureraj. So as you have already shown in your slides, based on data like the master DAPT or the stop DAPT trial, newer data is emerging, as you have rightfully mentioned, on de-escalation of DAPT timelines in patients who are the high risk subgroups. Clinically, what patient subsets would you be worried about so that we avoid these kind of bleeding events, so that we can consider de-escalation?
Basically, I think you have to assess your patient. There are these different scores for like the DAPT score and all those things that you assess. And then you assess the risk of bleed. Clinically, one of the very important factors that I already mentioned was hemoglobin. Anemia is a very important factor. It's often neglected as a bleed, previous history of bleed, uncontrolled hypertension. Now, all these scores are likely to change. They are not constant. And one more thing is, these are factors that you must keep in mind. There's already been a bleed, yes, fine. There's an anticoagulation, different story. I give you the protocol for that as low as possible, because the combination therapy is going to be more problematic. So when do you de-escalate? I think at this point of time, 6 months of dual antiplatelet therapy is the norm for anybody with a drug-eluting stent. We push it to 12 months if there is low bleeding risk, which is what happens most of the case. After 12 months, you can come down. And if it's going to be for an elective surgery, you want to stop after 6 months, it's quite safe. Remember that also. But ultimately, I think it is your clinical judgment looking at the patient where I think you should be looking at the patient and treating the patient individually. And I think the moral of the story about the dual antiplatelet therapy is what we're going to see in the future is very, very interesting. Because we have evolved, because the stent technology has improved. Ever since the imaging came in, our deployment of stent has improved tremendously. What we deploy the stents, there is very little under expansion. We are post-dilating aggressively, and these stents are doing pretty well, and they don't go in for a stent thrombosis. So I think we have made the change. We have created the change in a de-escalation, and I think it's likely to stay.
Thank you, sir. Thank you for giving us your insight on the same. I believe we are done with the questions, and with your permission, I would like to give each and every one of you the vote of thanks. So, from Macleods, on behalf of Macleods Pharmaceuticals, I, Dr. Parthasarathy, would like to extend my vote of thanks to each of our esteemed speakers Dr. Nair, Dr. Prajapati, Dr. Dureraj, for the wonderful sessions that you have taken. Each and every one of you have done justice within a limited time frame to discuss the topic right from physiology to pathophysiology to clinical concepts and merging that with in the background of the highest level of evidence and that to the latest evidence. We thank also the audience for being here, for enriching your own knowledge, taking out your precious time, coming here to enrich your knowledge. And we are very sure that this session would improve your clinical knowledge and help you with your patient care. Lastly, but not the least, we also thank our technology partners for helping us with the very smooth streaming of this webinar. Thank you, gentlemen, one and all. Thank you, audience, one and all, and wishing you all a very good evening.
Thank you so much.